I'm an MSN student at Liberty University Online, and I'm working with Dr. Barringer this semester. And I'm an ER nurse. And today we're going to talk about aortic aneurysms, and then we're going to hit cardiogenic shock. These are our learning objectives. I'll let you guys read that. All right, so here are some exciting statistics about aortic aneurysms. What I really want you to pay attention to on this slide is how many, especially abdominal aortic aneurysms, can be asymptomatic. Patients, 60% of abdominal aortic aneurysms, they don't even necessarily report pain. And then 75% of people diagnosed with aortic aneurysms have a history of smoking. Just a quick review for anatomy. Just want you guys to pay attention to the 3 different layers of the wall of the artery. And then remind yourselves about the descending thoracic aorta into the abdominal aorta, the distinction there, basically. Okay? All right, so types of aneurysms. The saccular aneurysm, B on the slide, is sometimes called a Berry aneurysm. It's the same thing. It's just going to be where the wall is bulging out to one side, versus a fusiform is where you have like a ballooning and it's bulging on all the way around. There's also something called a mycotic aneurysm, which is not pictured, but basically it's where the cause of the aneurysm is infectious in nature. I did put up the false aneurysm. It can look like an aneurysm, but as you can see, it's not a weakening of the wall. It's actually typically caused by like trauma, so maybe somebody's having a cardiac catheterization maybe, and an artery gets punctured. So typically it'll form like a clot there, and it can look like an aneurysm, but it is something different. And then dissection, which we'll talk more about dissection later, but dissections can happen at the same place of as where an aneurysm is happening, because you have a weakening in the vessel wall, but it's not the same thing. It's where you end up with like a false lumen. It's a tear in the internal layer of the wall, and you have blood flowing down into that false lumen and going up and down the side, or in between, in between the layers of the artery wall, okay? All right, so most common cause of all aortic aneurysms is atherosclerosis. I believe for abdominal it was like 75% of them specifically, but basically both thoracic and abdominal aortic aneurysms, atherosclerosis is your common cause. These are some other causes. This is not a comprehensive list, but inflammation, infection, like we talked about with mycotic wounds, and trauma. And if you guys, I did pass out those handouts for you guys, so you'll be able to kind of fill them in as we go. Okay, so I think that was one of them right there, okay? All right, so here are the risk factors. So you'll notice that the modifiable ones all have to do with atherosclerosis, right? For your non-modifiable, men are more likely to get these, white men specifically, and older folks, right? Women do get them, and actually if a woman gets an aneurysm, they're actually more likely to have it ruptured than a man, but men are just more likely to get them in general. And then Marfan syndrome is just an example of the congenital causes or risk factors, but there's some other ones as well, and I literally couldn't pronounce them, that's why they're not on the slide. What else? The smoking, not only are you more likely to get an aneurysm if you're a smoker, but you're more likely, if you have one, for it to rupture, okay? Just quick write down the risk factors that you can recall that we just went over, just so you guys are able to retain that information better. And just keep a differentiation between whether or not they're modifiable or non-modifiable, okay? There were only a couple, so if I'm not going to point to anyone, but if somebody wants to shout one out. Caucasian, good.
Smoking.
What was that? Smoking, great.
Marfan syndrome.
What was it? Over 65, very good. Yep.
Marfan syndrome.
And Marfan syndrome, great. That's awesome. Okay. Just wanted you guys to be able to remember those, okay? It's important. Here are the signs and symptoms. I did divide them thoracic versus abdominal. Remember that the abdominal ones are more likely to be asymptomatic. You can be asymptomatic with a thoracic aneurysm, especially the smaller aneurysms, they can literally be asymptomatic. Chest pain if it's thoracic, abdominal pain if they are having pain, it's going to be probably abdominal, it can be into the back. With the thoracic aneurysms, your signs and symptoms are going to be related to where the aneurysm is placing pressure within that chest cavity, okay? So for like the hoarseness, an example would be if the pressure of the aneurysm is being placed on the laryngeal nerve, that could cause hoarseness or aphonia. But each of those, like I say, are kind of based on where is that aneurysm and where is it putting pressure. And then for abdominal, another thing you want to pay attention to, the feeling of the pulsations. Your patient might say something to you like, oh, I feel like my heart is beating in my belly, beating in my stomach. That's a sign of, maybe we have an aneurysm going on here, okay? All right, so assessments. I know in lab a few weeks ago, we talked about bruits. You guys remember auscultating for bruits? But for abdominal aortic aneurysms, you're going to be inspecting first for that heave. Then you're going to be listening, auscultating for that bruit. And then you're going to be palpating for thrill. And you just want to be careful, we're not mashing if we're suspecting an aneurysm, we're just placing the hand and feeling gently. You may notice femoral pulses may be decreased. With the thoracic ones, again, it's going to be where is the aneurysm and how large is it and what is it putting pressure on. For example, the unequal pupils, this could be an aneurysm that's putting pressure on the sympathetic chain of the nervous system. And then also the diagnostics there. Chest x-rays, especially for the thoracic, CTAs, and then ultrasounds are going to be more like if you're having an abdominal aortic aneurysm that we're watching over time, which we'll talk about in a minute. They'll do serial ultrasounds with that patient over time to keep track of the aneurysm and its growth. So that's this here. So we have 5.5 centimeters is kind of typically when they're going to start intervening on abdominal ones. But it's going to be patient dependent, right? So your smaller people might not be able to wait that long. And with thoracic, there isn't just like a textbook number. It's more like how big is it or where is it? Do they have one of those congenital things like Marfan syndrome that's putting them more at risk for a rupture to where they can't wait as long for that surgical intervention? Blood pressure management and smoking cessation, these are huge for patient teaching. If you have somebody who does have an aneurysm, you really want them to be able to understand how important it is that they're keeping up with their blood pressure medications and that they are not smoking if they have been a smoker in the past. You also want them to have a low cholesterol diet because we talked about the atherosclerosis, right? And we do want these patients exercising. Exercising is good, but we want them to be careful that they are not lifting, really heavy. They're not like powerlifting or whatever. That would be increasing that like intra-abdominal pressure, right? All right, so we'll talk about ruptures and dissections. These are two separate things. Rupture is referring to the aneurysm rupturing, and dissection is how we talked about on one of the earlier slides where there's a false lumen being created and the blood is going in between the layers of the artery. But these two things can actually present kind of similarly, where they have that sudden onset of, chest pain if it's thoracic, or abdominal pain if it's an abdominal one. A lot of times that pain will be shooting through to the back. They'll say, pain in the belly shooting through to my back, to my lower back typically. The tearing sensation, if they say something, I feel like a ripping sensation, that's more classic of a dissection. They will have unstable blood pressures. Obviously, they're going to be exsanguinating internally, so dropping H&H. They may be approaching into a hypovolemic shock. This is a state of emergency if this happens, okay? Here are some, but not all, interventions. This is not necessarily like a comprehensive list, but we need to have access. We need IV access. If we can't get it, we're getting an IO because we absolutely need to have that access. We're going to be continuous hemodynamic monitoring. These are the labs. These are not all the labs. These are some of the labs. You want that type and cross because you may need to do a massive transfusion. You want your baseline coags, your baseline H&H and renal function as soon as this onset happens, right? You're going to get your baseline labs. You're going to be managing blood pressure and heart rate. I don't want to confuse you guys with this, but the rupture, you may go more quickly into hypotension. Dissection, you may actually see them go into hypertension, and then you may be actually managing that with something like a beta blocker in order to, what they call it, permissive hypotension, and that's just to sort of try to slow down the rate at which they're losing that blood into that false lumen. But either way, we're going to be expediting their admission to the OR because it's the only way. Yes, ma'am.
Can you explain to some people who don't know what IO is?
Oh, I'm so sorry. Yes, an IO is intraosseous. That's where they are going to drill into the patient's bone if they're unable to start an IV. So they may do it into right below the knee, or they may do it into the shoulder. And it's just like, hey, we can't get this IV, and we must have access. So we're going to go ahead and drill into the bone. And then the supplemental oxygen, because of course they're not perfusing well, right? And so that's going to be super important. Okay, here are our repair options. Typically, in the past, they've been doing more of the open surgical repair, but we're moving more now to where most people are getting endovascular repair because that's going to be less invasive. It's going to be where they go in through the femoral artery and place this graft. Okay, yes?
Just to make sure, are these only done on major veins and arteries, or?
This specifically is talking about the aortic artery.
Right.
So there are things that they can do. They can do repairs for other arteries in the body, absolutely. But these specifically are talking about aortic aneurysm repairs or rupture.
I guess because you can have a rupture anywhere in your body because we have arteries everywhere.
Sure.
But like, what makes it emergency? I guess that's my question.
This is your biggest thing this is your biggest artery in your body. This is a huge artery. And so if you have a rupture here, you have minutes. I mean, like, this is like, get to the OR yesterday, like immediately. Does that make sense?
I know this is a major,
Yeah.
But I'm talking about like arteries or veins in my arm.
Sure.
Or
I mean, anywhere that an artery ruptures is an emergency. Don't get me wrong. Okay, that's absolutely, all of these are emergencies. We're just specifically talking about the aorta with these today. Yes. Okay. We're gonna hit cardiogenic shock. I don't mean to rush, but we have only 10 minutes. I'm sorry. That's a good question though. So what is shock? Shock is a life-threatening disorder that results from insufficient tissue perfusion. Okay. There are many kinds of shock. You guys are actually going to cover the other types of shock later in the semester. So today we are only going to talk about cardiogenic shock. And it's an emergency. You need to be able to recognize the signs and symptoms. I want you to know that it is progressive. So it goes from compensatory to progressive to irreversible. And that's true of all shocks. They do that. And then I did put on there the multiple organ dysfunction syndrome is where you have at least 2 organs that are displaying signs of inadequate function. All right, so cardiogenic shock. This is where you have an impairment of your pump, your heart, and it's leading to end organ damage. This is because you have a decrease in your cardiac output. Remember that your cardiac output is your stroke volume times your heart rate. These are some of the causes of cardiogenic shock. I want you to note that myocardial infarctions are the most common cause of cardiogenic shock. I did not put up on the slide things like we talked about earlier, the cardiac tamponade or pneumothorax. Some people will categorize those as cardiogenic shock. I have always been taught that those are obstructive, but you will see them classified as both. Today, like I said, we're going to focus on MIs in particular, and as well as arrhythmias and valve disorders, okay? Here's your pathophysiology. You've got your decreased cardiac contractility, that's the strength, the strength of the contraction, and that is causing a decrease in your volume and stroke volume and cardiac output. So that's leading to pulmonary congestion. It's backing up into the lungs, right? A decreased systemic tissue perfusion to the body, and then decreased coronary artery perfusion, so the heart muscle itself is not getting the perfusion, the oxygen that it needs, and that is going back and further decreasing the cardiac contractility. Here are your signs and symptoms. It kind of all goes together with your assessment findings. You're going to see hypotension. You may see altered mental status. Hypotension lower than 90 systolic and urine output less than 30 an hour. These are concerning signs. Diminished heart sounds, the tachycardia, the JVD. This is starting to sound familiar from what you guys covered in your case studies. I'm falling behind on my notes here. Sorry. Okay. Here are some diagnostics. Again, not all diagnostics. I didn't try to hit you guys with everything. I want you to get these. These are the highlights. So that BNP is going to go up. Your cardiac enzymes, like your troponins, PK, that's going to go up. Your serum lactates will go up. You're going to be doing serial EKGs, or I saw you guys use ECG, same thing. What do you notice about the background of my beautiful slide here that I made? It's systemic, good. So, and I put that because I want you guys to remember that the MI is the most common cause of the cardiogenic shock. All right, so management. We want to restore cardiac output. Okay, that's our goal, and we want to identify the underlying cause. So these interventions are focused on MI because, like I said, that's the most common cause. But for example, let's say you had an arrhythmia that was causing cardiogenic shock. Well, we need to fix the arrhythmia. That's the cause. Okay. If you have a valve regurgitation, they need to get a valve replacement. That's going to fix the cardiogenic shock. But in the case that it's an MI, here are our main interventions. If we have decreased oxygen, like you guys' patient over here in your case study, we're going to be giving them oxygen. They may need intubation, especially if they're altered, right? If they're altered mental status and their oxygen is low, they're not perfusing. Intubating them actually would decrease the workload of the heart as well, so that may be a necessary intervention. Continuous hemodynamic monitoring, vasopressors, positive inotropes, the strength. Remember you guys talked about that in lab, the strength of the contraction, and then we also want vasodilators. So those two things, they don't work well together, right? So you're kind of trying to do two of the things. You want to increase the heart contractility while you're also decreasing the workload of the heart by causing that vasodilation. So you may see where you would give something like nitroglycerin for the vasodilating effect, as well as like norepi, okay? You wouldn't want to give something, my example is dopamine, because dopamine, although it is a vasopressor, it also is a vasoconstrictor. So that's just, this can be a little tricky when we want to do both of those kind of opposite or opposing things. We may give some fluids. We're going to be really careful about fluid overload. Because the heart is not pumping with great strength, we've already talked about that you may see the backing up into the lungs as signs of pulmonary edema. And so if we were to throw a lot of fluid at this patient, we would potentially cause that. And this is where this kind of differs from something like septic shock, which you guys will learn about later in the semester, which you're going to throw a lot of fluids at, okay? Or hypovolemic shock, okay? So this is where it's different, cardiogenic specifically. We got to fix the cause, right? So if it's an MI, we got to get them to the cath lab, okay? A PCI or a CABG, whatever they're going to do, we've got to restore perfusion to the heart muscle by opening up that coronary artery that's blocked. If you can't do that, maybe they're not stable enough for that, you may consider fibrinolytics. A lot of these patients will get aspirin and or heparin. And then diuretics. I know you guys talked about a little bit diuretics with your patient over here, and heart failure. It's the same concept where you have potentially the pulmonary edema. You're giving diuretics to try to draw off some excess fluid. But you're careful with this because these patients may be presenting with hypotension, and diuretics can worsen that. So this is a balancing act. It's kind of like the vasopressor vasodilator thing. This is a difficult patient to manage, okay? Here are some questions that I have. I made some fun questions for you guys. If you'll use your whiteboards or your paper, it doesn't matter. I want you to write down your answers before you shout them out and give everyone a chance to read. Has everyone If you're feeling confident, you can shout out the answer now.
B.
I heard B and D. All right, so if you said B, I want you to give me a rationale. Go ahead.
Well, I will say, well, I didn't read all of it, but, oh, never mind. Yeah,
That's okay. Somebody else who said B, yeah, go ahead.
Well, you said you could palpate it, you just gotta be nice and easy.
That's right, very good. So yeah, so this is kind of an order question, like these are all things you're gonna do, minus D, but these are all things you're gonna do, it's just that you're gonna be looking first, and then listening, and then palpating. Because of course you don't wanna palpate on the abdomen before you've auscultated, correct? Okay, so that was kind of the point with that question. Good job, good
What
job.
was the right one?
B is in Bravo.
B?
So, I'm sorry, yeah, B is in Bravo, so inspect first for the heaves, auscultate for the bruits, and then palpating gently for the throat.
Lead open.
Yeah. Good question, awesome. All right, next up, again, don't shout it out, give everyone a chance to read, please. Okay, anybody feeling frisky? Go ahead. Wait, didn't you answer the last one? Somebody else. All right, somebody else, go ahead. D, tell me why.
Because you said we didn't want fluid volume overload if we're already giving them the furosemide to take off the fluid. Why are we doubling down?
There you go, that's awesome. Right, so it's easy to look at this question and go, oh my gosh, 73/40, give them fluid. Right, that's kind of like your knee-jerk reaction. But if you read the whole question, you're like, oh, they got crackles in their lungs. So I want to be careful, okay? And we're giving the dobutamine, so we are addressing the blood pressure. Okay, last one. Good job so far. Somebody besides these two has to answer it, though. Go ahead.
A.
A, why do you say A?
Well, that's one of the two of the risk factors you mentioned before.
So I want you to read the question again. What do you see about the question?
I think it's C because if they have an aneurysm, they shouldn't live.
Very good. Yeah, so the thing that I was trying to point out to you is that it says further education, okay? So you're right, you absolutely would tell him, hey, or it's good if he says, hey, I'm an older man, I'm at higher risk, that's great. But what we're looking for is this patient didn't understand what I told him and I need to reiterate it, okay? So if he says, I'm gonna get back to powerlifting, then we need to say, no, you're not. How about some Pilates? Okay, does that sound good? All right, any other questions? Here are my key references. Thank you, guys.